if you're on that sideline, let's go back to the rugby, scenario. You got a player who's had a head, blow to the head, and you're trying to determine which direction to go. Assuming we have the test is validated and we have a positive test, can you just walk, listeners through how that would change the treatment then for a player and what they would go through in terms of that recovery process?
Yeah, that's an interesting one. So if we think about how, in terms of our understanding at the moment and how it might kind of pan out, it would be an adjunct to a setting where you've got a healthcare professional who can evaluate the player, and in settings where there's no healthcare professional, if we were to kind of imagine that we're a little way down the track, that may be something which replaces an assessment altogether because there's no one there to do the assessment. One thing that we're trying to establish now in the further research that we're doing is to figure out, well, what happens next? So what can we take from the measurement of these markers or different markers to understand, can we advise on when someone has recovered? And can we advise on what sort of symptoms someone's likely to get? And so therefore, what kind of treatment might they respond well to? So one of probably the most exciting areas, I think, in terms of concussion research is on the active management of symptoms, with some amazing work being done on particular sort of subsets of symptoms, and on managing athletes actively and non-athletes as a whole. So what would be really cool is if we could contribute to that and say, well, there's a X percentage chance that this athlete is going to suffer with these problems, therefore get in with that targeted rehab early, and you'll see them do better. And likewise, we're unsure, but potentially we may be able to get to provide some information on predicting that this is someone who's going to take this long to recover, or this is someone who's going to have a more complicated recovery, and so therefore needs maybe additional follow-up or additional care. But those are kind of questions we're trying to figure out answers to.
Absolutely. I mean, it's fascinating stuff. And Patrick, when we look across the broader network of other tests out there, or other groups that are trying to assess for head trauma and similarly acute diagnosis, are there other types of tests or other things that are being investigated in that realm, or on the or even on the recovery side that are out there at the moment?
Yeah, there are a few things kind of going on, and a similar kind of conversation is happening with other biomarkers in the field as well, to look and say, say for example, biomarkers in blood, if we can use it for diagnosis, can we use an understanding of how quickly it normalizes or when it normalizes to help guide us with that? There are some elements of MRI brain which are kind of feeding into that as well. So some studies that have looked at a particular way of imaging the brain called spectroscopy, which looks at MRI evidence of metabolic activity in the brain, effectively, to kind of give an idea of when metabolic recovery has happened and when it's still kind of incomplete. And that's a similar sort of concept to say, okay, maybe this person is no longer reporting any symptoms and their clinical examination is back to normal, but actually we can still see evidence that their metabolic recovery, in inverted commas, isn't complete. And likewise, some other metrics of MRI also, which are being looked at, to do with the way different parts of the brain sort of work together and communicate.
So, and Patrick, is that the difference then between, sorry to jump in, is that the difference then when we hear about the difference between clinical recovery and physiological recovery, that notion that those symptoms look good on the outside, but when we do this deeper test, we can see that some of these secondary cascades, there's things going on that are still abnormal?
Yeah, totally. And that's there's a lot of kind of examples of that out there where, the patients patient's well again, not reporting any symptoms, they're back at school. They're, you know, if you didn't have any extra information, then you'd be saying, okay, let's start your return to play. But this thing that we're able to measure still hasn't gone back to your baseline or the population baseline. And at this stage, if you think about the kind of studies you need to do to understand that, at this stage we can say, well, that's really interesting, but it's unclear whether it's important. Because almost you need to follow that person up then. You say, okay, your spectroscopy, say, hasn't gone back to normal. So we're going to let you go back to sport, and we're going to watch and see what happens to you. And we're also going to watch these people whose spectroscopy did go back to normal, and we're going to let them return to sport and follow them up and see what happened to them. And so it takes a long time to understand, like, was that a good decision or a bad decision? And should we be kind of giving more weight to those sorts of measures in clinical situations? But they're hard questions to answer.
Absolutely.
And so the best way I can describe it is like you read a paper and you think that's really interesting, but I don't know if we know if it's important yet or not.
Yeah, and on that point around, you know, in your experience when working with athletes and having that discrepancy between sort of clinical recovery and that physiological recovery, are there certain patterns or themes that start to emerge, whether it's from symptoms or things that come up in the tests, or is it really just that individual between the athlete and the sport and the nature of the injury?
Yeah, I think probably if you think about the clinical situations that come up, more and more now we're looking for things like neck, like cervical joint position error testing, and assessments of the vestibular ocular system and vestibular ocular function to help us pinpoint, okay, if you're having prolonged symptoms, then you know, is this a driver? And we can use that to treat you and to get you better. I think what's a little bit less clear is if you look for those sorts of things in people who've had their acute injury, then you may well find that they're abnormal or that they provoke symptoms. But does that mean that person would benefit from treating those or from reassessing those until they've gotten better? Or actually, is that a person who, were it not for you testing those things, would have gotten back to school and to their sport, you know, without any issue? And likewise, you know, you may find that you start to see some of those things included on your baseline assessment in your preseason. And if you find someone has a deficit or an issue, does that mean that you're not going to let them do contact until you've kind of done some remedial work on that, or are you just going to watch that and monitor it? There are some difficult questions to answer, and inevitably you've got to be a bit sort of pragmatic with it until the research comes along to back it up. But I think there are situations like that where you think, okay, on this particular balance measure that we don't have a baseline of, you're abnormal in inverted commas. But what does that mean? Does that mean that we're never going to let you return to your sport until you've got it, which may be never? Or are we going to kind of go with the general direction of the other measures that have normalized and use that?
Yeah, absolutely. I mean, it's obviously so tricky to navigate all the subtleties and nuances that come along with it. And you know, in your experience, again, working with athletes on the recovery side, when we look at things like medications, which are used to treat some of the secondary symptoms that people get from concussions, but of course, a lot of those medications have side effects that mimic some of the symptoms of concussion. So there's certain, you know, medications that you might be more leery of providing with patients depending on symptoms, or other medications that might be, you know. Obviously, I appreciate this is very individualized to the athlete, but you know, it's definitely a question that comes up with a lot of the athletes that I see, and with practitioners as well. Any insights there?
Yeah, I think that as you say, the most important thing is that it's individualized to the athlete, and the best that we can do, I think, in my opinion, is to try and get an idea for each athlete of what are the issues, what's the predominant thing that's driving the symptoms, or combination of things that are driving their symptoms, and what can we do to address that. And I think in terms of the differences in practice that I've seen in different places, so I went and spent some time in a clinic in North America, and there they were much more readily using medication for specific types of symptoms. So, for example, adolescent athletes who are struggling to sleep would be given melatonin to try and help support that. Or if athletes were having migraine type of symptoms, that they were given medication to abort migraines or to prevent migraines. And I think that's something that in other clinics, clinicians are a bit more reluctant to do, because there's a feeling that time and rest have been crucial parts of the treatment previously, and so therefore probably this is a signal that we need to give a little bit more time. But actually, the two can coexist. It may be a signal that that athlete needs more time, but you're probably not doing them any favors by letting them continue to have really troubling symptoms that are making them worry that they're going to have migraines forever, or really preventing them being able to concentrate for their return to academic work because they haven't sort of slept the night before. So I do think it's important that we're not shying away from using medication when it's necessary, but definitely that we kind of use it in a measured way, because like you say, there's some medications we commonly use for things which will have side effects or actually which are great. For example, migraine's a good example. There are lots of medications that are great for migraine, but they're not really brilliant for young active people because they do affect their exercise capacity.